Hi, my name is Teresa Harrington, and I'm here to present our Learning Contract Project, How Federal Policy Changes Impact State Agency Budget Processes, an analysis of the impact of Medicaid expansion on the Central Oklahoma Community Mental Health Center. My group members were Jasmine Baron, Mario Flores, Loretta Garner, Andrea Rivera, Muafaka, Sunthi Elnazar, and myself, Teresa Harrington. So the idea for this project came from our group member, Muafaka, who works for the Central Oklahoma Community Mental Health Center. Our project had two main objectives. First, to explore intergovernmental relationships through the example of Medicaid expansion. Specifically, we wanted to look at two things: the impact of expansion on state budgets and the effect of state politics on Medicaid expansion. The next thing we wanted to do is examine the challenges that a change in federal policy like Medicaid expansion might create at the agency level and understand how fiscal administrators deal with these challenges. So our project had three parts. We prepared a research paper, we conducted a case study, and then we prepared our annotated bibliography. Please note the project doesn't examine the impact of Medicaid expansion on the federal budget, though this is really another interesting conversation. All right, so what did we learn? We learned that Medicaid expansion provided expanded eligibility for millions of Americans by changing the criteria for qualification, expanding the entitlement to all low-income people who met the income threshold of 133% of the federal poverty level. So the deal the government was making is that they would pay 100% reimbursement for the first 2 years of this program, with states gradually taking on some financial responsibility for the program, capping out at 90% federal funding, 10% state funding. This was still a much more generous reimbursement ratio than traditional Medicaid offered. So initially, this expansion was a mandatory part of the Affordable Care Act, but several court challenges led to the expansion being determined to be only constitutional if states were allowed to determine their own participation. So expansion had to be adopted through each state's political process. Some states were really eager to go ahead and expand and provide health coverage to more citizens, but many states feared that the growth of an entitlement program would be a problem. So unlike federal government, states have to balance their budget, and accepting the expansion could really place an onerous burden on state budgets. However, our research into expansion states revealed that states who adopted Medicaid expansion actually saved money in other budget areas. They spent significantly less on uncompensated care, behavioral and mental health services for low-income clients, and hospital reimbursements for inmates that were now covered under the Medicaid program. Furthermore, many states saw increased revenue as they were able to collect additional tax revenue from taxes on healthcare providers. One of the studies we looked at was from the Commonwealth Fund, and that study concluded that states actually had a variety of means to offset some or even all of expansion statutory costs. Thus, the net cost of Medicaid expansion to states was really different than that 10% sticker price. In some cases, it was even net negative, which meant that states made money off the Medicaid expansion program. So from our case study, we learned several important things. First, Oklahoma, like other expansion states, realized considerable savings from the Medicaid expansion in the area of uncompensated care. Next, we learned that Medicaid expansion actually prompted the state of Oklahoma to change its service delivery model for mental health. It adopted a certified community behavioral health clinic model. This model was adopted mainly because it afforded the state the highest potential for Medicaid reimbursement, and it was also considered a good model for overall health service delivery, a win-win for everyone. Lastly, this transaction was really hard on the fiscal administrators at the agency level. While the CCBHC funding was available to hire clinicians and providers, they only hired one additional administrative staff member, and no additional fiscal administrative staff were added, even though this change meant a lot more work at all levels of the budget process. So what were our main takeaways? First, fiscally Medicaid expansion appears beneficial to states and has the potential of providing better health outcomes. Next, state decisions around whether or not to expand Medicaid seem to have more political than fiscal motivations. But despite that fact, the issue does not divide strictly along party lines. And finally, even if the impact on state budgets is minimal, the burden for state agency level fiscal administrative managers is not. There's very little research on the cost of the administrative burden this type of transition can create. So this project really underscored the need to ensure that there is solid investment in fiscal administration and infrastructure in order to implement Medicaid expansion responsibly and ensure sound fiscal management of the billions of dollars that are appropriated through this process. Thanks so much for listening. We've posted our paper, case study, and annotated bibliography on the blog, and we look forward to your questions. Thanks a lot.